request Dr. Nandha Kishore to take the stage to oppose the motion.
Yeah, thank you. Actually, I was thinking like Sunil has made my job easy because at a time while going through his presentation, I thought, I mean, he was actually talking pro for me because the topic was early vasopressors in sepsis, less is more. But I'm going to speak like less is not more. So the basic question comes like why should the vasopressor agent be started as early as possible in the duration of the entire course of sepsis and septic shock? So so if you go back to the basic pathophysiology of sepsis, the first reason is what actually happens in sepsis. There is a severe vasodilatation, as we all know. There is a loss of vasomotor tone that happens, leading to venodilatation and pooling of blood in the veins. There is a decrease. There may be a hypovolemia, but which is always relative. Absolute hypovolemia only happens as per the different etiology, but most of the time it is a relative hypovolemia and the loss of vasomotor tone that is the predominant pathophysiology behind septic shock. And apart from these two, there is also a myocardial depression involved. So what happens when we give more fluids and when we delay vasopressors? When we delay actually the vasopressor, the vasodilatory phase keeps on continuing and the loss of vasomotor tone also keeps on continuing. And when you initiate an early vasopressor, probably you are combating this process of pathophysiology and you are trying to halt this process and probably look at improving the vasomotor tone, improving the unstressed volume, bringing back into the stress volume, and probably increase the preload and mean systemic filling pressures. So the second reason why I can clearly tell that you should start early vasopressor support is probably the autoregulatory thing. We all know the vital organs like the kidneys, heart, and the brain, they follow an autoregulatory pattern of blood flow when there is an increased metabolic demand. We all know there is an increased metabolic demand in septic shock, and when this happens, the vital organs try to maintain the blood flow to these organs through a mechanism of autoregulation. But unfortunately, in septic shock, this autoregulatory mechanism is lost and the organ perfusion pressure is directly proportional to the mean arterial pressure. This becomes the main thing. So when compared with these organs, other organs like livers, pancreas, and stomach, and the intestines, which have very weak autoregulatory mechanisms, cannot cope up. And the perfusion of these organs is purely dependent on the map. So unless you improve the map, the organ pressures are not going to come up. So the third reason is the first reflex compensatory mechanism when a patient comes with septic shock in the body that happens is the release of endogenous catecholamines, and this causes splanchnic vasoconstriction. So the simple ideology is, so if the body itself is trying to produce catecholamines as a response, why not supplement the same catecholamines externally early in the course of the disease? This is the third obvious reason. And the fourth reason, we all know, we have been taught from ages that fluids are harmful, they have detrimental effects. Your positive fluid balance is obviously dangerous, it can cause many side effects, and vasopressors can actually reduce the potential harmful side effects of these fluids. We all know the harmful fluids of effects. Harmful effects of the fluids are like it can damage the endothelial glycocalyx, it can increase the vascular permeability, it can cause organ venous congestion, it can increase the unwanted unstressed volume. We don't want the unstressed volume to increase. But actually, when you give fluids, you're not increasing the stressed volume. You're increasing the unstressed volume, which we don't want. So what do? You give vasopressors to combat these side effects. Vasopressors increase the vasomotor tone. They actually shift the unstressed volume into the stressed compartment. They increase the mean systemic filling pressures. They also increase the cardiac output by increasing the preload dependency. They don't increase the preload dependency, but they increase the vasomotor tone and cardiac contractility, thus causing increase in the cardiac output. And they also increase the diastolic blood pressures, thus improving the coronary perfusion pressure. This is one more reason why I want a vasopressor agent very early in the course of sepsis. And the fifth reason, which I tell always, is recent evidence shows that only 50% of the septic shock patients are actually fluid responders. The moment the patient comes to the emergency room in a septic shock, he may not be a fluid responder. That means the fluid given to them actually may not translate into an improved stroke volume or a cardiac output. And hemodynamic effects of a fluid bolus are very short-lived. You give a fluid bolus and observe an increase in stroke volume. That sustained effect of increase in stroke volume or cardiac output is not very for a huge time. It lasts hardly for a 60 minutes. That means if you're trying to focus on the intravascular volume, you're not going to achieve much. So and the recent evidence as per the Andromeda shock trial tells you that fluid responders within no time can become a non-responders. If you look at the sub-analysis of this trial, fluid responsiveness actually disappeared in almost all the patients during the 8-hour intervention period and after receiving the median fluid of around 1.5 liters. So this is the basis why I need to start early vasopressors. And fluid bolus itself has shown that it can cause severe vasodilatation through different mechanisms. And the sixth important reason which we should emphasize is the complex hemodynamic profiles. Whenever a patient comes to the emergency room with a septic shock, there are different hemodynamic profiles of the presenting patient. He can be fluid responsive, but still may not be a fluid tolerance. The fluid tolerance is a new concept which we have to emphasize in a patient with septic shock. A patient with a fluid responsive can be a fluid tolerant as well. A patient who is fluid responder may not be fluid tolerant. So these are the four hemodynamic profiles, and you don't know which hemodynamic profile is fits into this patient as long as you go and apply an advanced hemodynamic monitoring. So in that case, you cannot apply and start giving fluid resuscitation, and rather the best option is to start an early vasopressor agent. So what is the evidence in favor of starting the early vasopressors? As my friend Sunil told, I will quote the same evidence, the sensor study and the major studies which have been put it in a single nutshell. All these studies, they have divided into early vasopressor group and the late vasopressor group, and they found that all the studies have shown clearly the mortality benefit, and every 1 hour delay in the initiation of early vasopressors probably increases the mortality. And when you start the early vasopressor, there is a significant mortality difference, and also the shock reversal was much quicker, and the lower cumulative fluid balance was seen in the early vasopressors group. And we quickly put into the pooled analysis at the forest plotting, it clearly shows the relative risk ratio of around 1.1 in all the studies, and have clearly shown that early vasopressors definitely improves the mortality. So is there any parameter to guide? There are parameters to guide fluid resuscitation. We apply many parameters like dynamic variables, but are there any parameters to guide the initiation of vasopressors? Yes. If a patient is present with a low diastolic blood pressure, probably there is a severe vasodilatation. If the patient is present with an increased shock index or a diastolic shock index more than 2.3, or you can apply the dynamic arterial elastance. If the dynamic arterial elastance is low, it reflects that the systemic vascular resistance is low. And the subset of patients presenting itself will tell you whether to start the vasopressors early or not. Suppose a patient coming with a myocardial infarction or a cardiogenic pulmonary edema, it's obvious that you don't give fluids, but you start vasopressor agents. So is this a final nail in the coffin for fluids when compared to the vasopressors? As clinicians, we are definitely bound to deviate from the guidelines when such deviation is expected to improve the patient outcomes. Definitely, yes, I will not look each and every patient as a single entity. I will take differently. It is a subjective assessment. I will take each individual as a different patient, and I will not give 30 ml per kg of crystalloids to each patient of septic shock coming to the emergency. I will differentiate my patients, fix his hemodynamic profile, and probably think of starting early vasopressors. Mitchell Levy has clearly stated that the surviving sepsis guidelines probably do not represent the best distillation of scientific information, and they do not need to be rigidly followed. So as my friend Sunil quoted, this is the major evidence which he has put, the last evidence, the current use of vasopressors in septic shock. This is the recent information, a group of 34 members of the ESICM who are considered to be the experts in hemodynamics have formulated recommendations, and one of the recommendation tells that you should administer or you should consider administering norepinephrine in the initial phase of fluid administration and before completing the correct entire fluid administration. That means even the hypovolemia is not corrected completely, you can still start even initial vasopressor agent, and this was the consensus agreement, and 70 to 80% of these experts have agreed on this statement. So to conclude, early administration of norepinephrine definitely increases the survival rate and shortens the duration of hypotension, improves the organ perfusion. But now, how much early is too much early, and what is the best time to start vasopressors? Maybe there is not of much evidence, but definitely the answer for these questions will be probably available soon. And we definitely need a large randomized control trial to fill the knowledge gap with respect to the timings. And irrespective of all these things, what I have said in this presentation, common sense should prevail us to optimize the circulatory dysfunction. And in septic shock, the decision path is very clear. You need not have a second thought to start your vasopressors. They need to be instituted immediately. So my take is start the vasopressors as up. And this is my disclaimer. Without early vasopressor support, fluids alone cannot do the job. And so less is more holds may be possible for the fluids, but not for the vasopressors. So I hereby tell that vasopressors for vasopressors, less is not more. The more early you start, the better are the outcomes. Thank you.
Thank you, Dr. Nandakishore and Dr. Sunil. Both of you have presented excellent, compelling evidence to support your points, but at the end, it sounds like me that both of you supported the motion. Both of you are actually talking about giving early best versus. And the organizers are very clever. I will tell you why. They made it into a tribate, not a debate. Where I don't know, they have to advise me whether I should give them 1 minute each to close their arguments. No, that's not designed. Thank you. So in the tribate, they also said that I should be the balancer. Um, so they said I should be the balancer. Now the balancing seems to be regarding fluids, not between these two people, isn't it? Fluid balance and that kind of things. And Nandakishore said something very important toward the end of his lecture, common sense, isn't it? This is a very vital issue. We face it every day in our practice. Several trials have been done, and I don't need to elaborate any more trials. My young friends have put in enough trials in front of all of you to decide. You can go home and read them at length and decide whether you want to do or not. And he also used another word, both of them used this word early. This early is a very, very deceitful word in medicine. How early is early? And what do you mean by early? For example, you are using early vasopressin or early noradrenaline. Let us say most of the studies have put 6 hours as a mark, isn't it? It is 6 hours for you in the hospital, not for the patient, because we don't know when the patient sepsis started. It must have started yesterday. It should have gone to an RMP. It should have gone to another hospital. It must have come from a distant place. It's not early for him. It's early for you and conveniently defined by you. Now, I don't agree with one of the points my young friend said that in almost every case, you better give early norepinephrine or vasopressin, whatever the choice may be. Because all of us agree that we have treated thousands of cases without giving any inotropes. We just fluid resuscitated them, they became all right, isn't it? The second variable that we are facing is we are treating all sepsis cases as a single cohort. They are not. For example, you can ask your seniors or from your own experience, a pulmonary sepsis behaves very differently from a urosepsis. And you give fluids for both because both have vasodilation, both have relative hypovolemia and capillary leak. Maybe it has started. Now the question is the amount of fluid that you give before you start norepinephrine, early norepinephrine, I agree for that, is defined by need for deresuscitation later. You should not exceed the point of total volume of fluid given before you give norepinephrine or vasopressin if you may choose so. And the volume you cannot say today. You will say 48 hours later that this patient has been given excess fluid, he leaked into his tissues, now he needs deresuscitation. So someone has to come out with strong research, numerically with a good power research, with need for deresuscitation as an endpoint. If patient needed deresuscitation, that means the so-called early for you is delayed for him. You have given fluid to a leaking patient, and this man needed deresuscitation, thereby increasing the organ dysfunction. I have seen in my own practice that I keep saying this to my colleagues that infected organs leak more. For example, I'm very afraid of giving extra fluid to pneumonia patients. I'm not that afraid to give to urosepsis patient, and of course I agree with you with myocardial ischemia patient. Several studies have been done. Even our department has done a study as a postgraduate thesis for Dr. Ram Bhupal, who is exam going DRNB now. We are completely in line with the Thai study that you have shown. I think Thai study did a total of 300 patients, if I'm not wrong, isn't it? And they did not show any mortality difference. So coming back to balancing the amount of fluid that you want to give to a patient before you start noradrenaline is a very difficult thing. It's not easy. It's going to be very difficult. It is going to be very, very dependent on which organ is infected, at what point of his disease evolution patient has presented to your ER, because ER people work on the patient for a few hours before they give it to you. And I don't know whether they are discussing all these studies. We don't have any standard guidelines. Miss Levy has contradicted. I have read that statement before. 30 ml is not more than 30 ml, not 30 ml. Why did he say not more than 30 ml? Because we are sure that you keep pushing fluid, you will get into interstitial leak syndromes a day or two later. And now regarding the inotropes, I come from the generation where dopamine used to be the first line of the inotrope that has gone out of window, especially in some countries in India also. We were giving noradrenaline as a delayed choice. We were using adrenaline as a primary choice. Now noradrenaline has become a primary choice. Slowly vasopressin is also moving into the early stage. Now we've got angiotensin 2 coming into the market. So it is a complex situation. So there is these many variables. The time of presentation of the patient, the infected organ, whether already leak has started or not, what inotrope are you choosing, what fluid are you choosing, and what is the quantity of the fluid that you want to give before you start the inotrope. That quantity is very difficult to decide in my experience. If you simply go by hemodynamic parameters and don't look at leakage, which is decided by glycocalyx, as you correctly said, you have given excess fluid. Even if you have given 1 liter fluid, that's excess for him. So balance out is individual with the current available evidence that we have. Definitely the time period in which we have to give vasopressors, noradrenaline in this particular case, has moved earlier than what it was a few years before. Vasopressin is also trying to enter that place. I was very afraid of vasopressin in the initial years, especially in patients who had myocardial dysfunction, etc. But now have learned much more about vasopressin, how to use it, etc. So looking at the individual patient, infected organ, and whether leakage has started or not, you have to stop or reduce giving fluid and start vasopressor at that point of time. But we need more data. We need more studies with multiple inotrope, multiple organs, infected organs, and time of presentation is something that one metric has to be introduced into these studies. Till then, I think using the available evidence, we do consider vasopressors earlier than what we used to do to benefit the patient. And if any one of you are going to do any studies or a thesis to your students, I would definitely put the need for deresuscitation as a marker of the fluid that you have given. So if anyone of my senior colleagues want to say anything about this important topic, I know it's getting late now. There is another kind of fluid waiting somewhere else, so we don't delay for that. Would you like to say one sentence each? Please come. I'm taking the liberty.
So, as per the SSC guidelines, I mean, 1 hour was the bundle actually. So, starting a vasopressor within 1 hour was the initial choice by them by 2018. But when we have seen the evidences and all these things, it can be like 1 to 6 hours now. Okay. And moreover, the driving force for the vasopressors was the diastolic blood pressure or diastolic shock index or something like that. We can enumerate 10 to 20 causes of having a diastolic blood pressure lower side. Like if you have a patient, debilitated patient present in your ICU for long durations, almost a month or so, a cancer patient or anybody who is bedridden or alcoholic patients. So they may have a diastolic blood pressure on the lower side, and diastolic shock index can be on the lower side sometimes. So these were the contradictory statements which were going against using vasopressors too early. Thank you.
So as I told, how much early is too early. Probably we may not find a solution or a proper strong recommendation to it, but I am sure guidelines are meant to be changed. The surviving sepsis guidelines are not the same over the past 20 years. There have been a lot of significant changes that have been documented in these surviving sepsis guidelines. They were not the same in 2001 and not the same now. So I am sure, pretty much sure that in the next, probably in the next or few years, they will definitely implement this recommendation, strong recommendation that early initiation of vasopressor should be done. What is the time duration? Probably early as 1 hour, and not for all patients, but probably they would come up strongly with some recommendation. And as I told, we need some guide or some marker to tell that okay, this is the time where you need to start early vasopressors. Unfortunately, at this moment we are not having a strong marker, but still there are, as Sunil told, diastolic shock index or dynamic arterial elastance or some other thing. You can apply something, but whatever and have said, delay in the initiation of vasopressors had led to significant mortality. That is one thing I can owe on to, and that's it, sir.
Yeah. Excellent education of both the sides and a balanced view, sir. I think common sense prevails in a little more addition to that. I will look at the patients presenting blood pressure or presenting perfusion. If the perfusion is compromised to a very bad extent, we see a spectrum of hypertension. Patient comes with a systolic BP of 80, patients comes with a systolic BP of 40. So we call both of them as hypertensive. So for a 40 blood pressure or a 50 systolic blood pressure with a map of around 20-30, probably I will not compromise those 15, 20, half an hour, 1 hour, 2 hours also. Somebody whose systolic blood pressure is 80 or 85 with a map of already 50, 55. I have a scope. So if I have a very refractory or a very low blood pressure patient with a compromised perfusion, lactates rising, well, I'll consider both together and later optimize. I have some space of that. But if my pressures are on the other corner of that, probably as all of you said, assess all of them, start one of the other, wait to stop, you can take time to balance them. But in a very, very lower pressures, probably I will not wait the pressure pressures to be started. What we do in a massive, even hemorrhagic shock, I know the hemoglobin is dropped from 10 to 2 and my BP is dropped down to 40 with some massive blood loss. We transfuse or we replace volume, we replace RBCs, but in the meantime we also try to keep the map little somewhere around 50 or 55. We'll not allow the whole the time till we fill them back. So the reason is maintain some amount of perfusion. I think that's an add-on point, that you grade the pressures. If it is too low, you probably add both of them together, take your time to adjust later.
Thank you, sir. This is a wonderful insight. So probably achieving the map target at the earliest with the help of fluid or vasopressor, whichever. So I'd like to call sir and our fellow speaker, Dr. Sunil and Dr. Nandha Kishore for a felicitation. Sir, wait please. Sir, I like to call Bhavanya sir, Chairman Hyderabad ISSM for felicitation PBN sir. So for further proceeding, I'll hand over podium to Dr. Bhavani sir.